Wonderful. Thank you so much for that kind introduction, Sarah. And I'd like to thank you all for the opportunity to speak to you. It's quite an honor and a privilege to talk about this, such an important topic. I have to give a shout out to our pathologists who really do so much to help us get the mutational testing that is helpful for us. And I do feel blessed that we're able to, in many instances, get that here in the US, but we know there's a limitation elsewhere. So I'm going to be focusing on the clinical aspect of GIST mutational testing. So I am going to start with some of our learning objectives. What I thought would be helpful is to really focus to start with what we know about the different drugs that we use the most in GI stromal tumors and how they act with mutations by going through some of the seminal studies. And then we'll talk about how we can use, when we can get the information, primary and secondary mutations as a guide for choice of therapy, and then some options for specific very rare mutations. So as all of you know, our major drugs that are used for GI stromal tumors start with our old favorite imatinib. And I apologize for not having all the agencies up here, but imatinib, as you know, was approved back in 2001 for GI stromal tumors, both in the metastatic and then eventually the adjuvant setting. Sunitinib is approved after imatinib failure or intolerance. Regorafenib was approved back in 2013 with after imatinib and sunitinib failure. And then Avapritinib was just recently approved, which is very exciting, was really approved based on a mutational status. So patients with PDGFRA alpha exon 18 mutations, including the typically imatinib-resistant D842V mutation, he has had a new drug. And then Ripretinib is also a new drug that's approved by the FDA and is under evaluations in the EMA, and was approved by the FDA after 3 or more prior tyrosine kinase inhibitors. And this is going to give us a taste of how we are able to now think about secondary resistance mutations. So as we go through these different drugs, I'm just going to remind you all, most of the data we have is based on the most common mutations, because a lot of the studies looking back really could gather this information most commonly. So we know most about exon 11 mutations, which are most common in KIT exon 9 mutations, and then some of the PDGFR alpha exon 18 mutations. So kind of moving forward to talk about imatinib. So as you know, this is our kind of rock star of medications in the GI stromal tumor world. So one of the larger studies that was conducted to garnish imatinib approval went back and gathered as much mutational information as possible. And we're going to be looking at some curves that many of you may be familiar with, but these are progression-free survival curves. There's a lot of different curves we can use, but thought it would be best to focus on progression-free survival. And on this side, we see the percentage of patients' tumors who progress, and then the time they're on treatment. So basically, the further out the line indicates the longer amount of time a patient was able to remain on study. So this just points out in blue, patients with exon 11 mutations tended to stay on imatinib for longer, thus meaning that those mutations tended to benefit longer as compared to the exon 9 and wild type mutations. Now, we know a lot more about wild type than we did when these studies were published. We know that wild type doesn't mean that there were necessarily no mutations, but there were no mutations that were detected at the time. Another way we kind of look at benefit that I might mention periodically is by response rates. There's no perfect way to judge benefit across large studies in this disease. So we often use a combination of response rates, which is tumor shrinkage, as well as progression-free survival, like these curves we look at here. So we know that the exon 11 mutations tend to shrink more often using imatinib as compared to exon 9 in wild type. So kind of in summary, from the early studies, we learned that GIST with KIT exon 11 mutations are controlled for longer in general with imatinib as compared to GIST with KIT exon 9 mutations in wild type. I wanted to point out that this doesn't mean that patients with exon 9 mutations or wild type don't benefit from imatinib. These are just generalizations across many people. And all of these decisions need to be kind of considered individually. The early studies with imatinib also looked at different doses of imatinib because initially we didn't know which would be the correct dose for patients. And 2 doses were studied in several different large studies of imatinib in GI stromal tumors. And this is one of the first areas we learned about the difference in mutations in patients that were treated with standard dosing, which is usually 400 milligrams of imatinib, as compared to 800 milligrams of imatinib. For patients who had exon 9 mutations, they tended to do better or take longer to progress when they were treated with higher doses of imatinib. Patients with exon 11 really didn't seem to have as much of a difference. We also saw that response rates were higher with exon 9 mutated GIST based on a higher dose of imatinib. So here we learned that exon 9 mutant GIST were more likely to be controlled with higher dose imatinib. And that is also kind of a therapy strategy that medical oncologists use. Next, I'm going to touch on sunitinib. So as many of you know, sunitinib was approved based on phase 3 studies in imatinib-resistant GIST that showed that sunitinib was better than placebo, thank goodness. So patients that were on sunitinib did better as opposed to patients that weren't receiving any drugs. Now, when we look at the activity based on the mutation, we learned this in smaller studies and then even longer studies. I'll give larger studies. I'll give a shout out to my colleague who's going to be speaking next, Dr. Reichert. Many series have shown that patients with exon 9 mutations and even wild type tend to do better for longer than patients with the exon 11 mutations. That doesn't mean that patients with exon 11 mutations don't benefit, but in general, what we've learned over the years is that patients with GIST with KIT exon 9 mutations and wild type were controlled for longer periods of time with sunitinib as compared to KIT exon 11 mutations. Later on, we've also learned that sunitinib can also have activity in GIST with KIT exon 13 and 14 mutations. The next drug I was going to talk about was Regorafenib. So this was studied in patients with imatinib and sunitinib-resistant tumors. And you could see this also did better than placebo with patients taking longer to progress when they're receiving Regorafenib versus placebo. The data we have basically confirms that Regorafenib, this is another way we can kind of look at data and the exons changes. And the summary here is that basically just with both KIT exon 11 and exon 9 mutations had better results compared to placebo when they were controlled with Regorafenib. And later we'll also touch on how Regorafenib can also have activity in kind of our resistance mutations, including exon 17. Next, we'll talk about Avapritinib. Avapritinib, as you know, is approved in PDGFRA alpha mutant GI stromal tumors. And this was actually based on a very early phase study that included quite a few patients where they looked at patients with PDGFR mutant GI stromal tumors and showed very impressive response rates. And as to date, the progression-free survival is ongoing. There was a particular benefit or tumor shrinkage seen in patients with the D842 variant, which was really the first time we were seeing really impressive activity. Avapritinib is known to be very selective in blocking GI stromal tumors in a very particular state in their tyrosine kinase that is associated with PDGFR alpha D842 variants. So here in this study, we learned that this strategy of avapritinib was useful in patients with PDGFR alpha mutant GIST. So we're learning all of these different pieces of information from each of our drug studies, and we'll summarize in a minute, but most of these were based on kind of primary resistance mutations. As learned from our pathologists, that we're also learning a lot about secondary mutations or resistance mutations that happen over time. These can happen in different areas, and this is just one slide kind of covering how we might have a primary mutation in exon 9 or 11 commonly, and then later on, patients or tumors can develop these secondary mutations that confer resistance to the medications they've been on. So our next drug, Ripretinib, is one that does have kind of a different mechanism of action in terms of how it inhibits the tyrosine kinase, and it binds two different areas and is thought to broadly block multiple mutations, many of which are implicated in resistance. So this is kind of our latest drug approval in the US and hopefully broader areas soon, that showed a benefit as compared to placebo with Ripretinib. And this is in patients that have had over 3 other tyrosine kinase inhibitors in the past. So really, we think targeting some of those resistance. The exact mutation data is starting to be presented more and more. But this is a slide I stole from one of my colleagues, Dr. Trent, based on a study we conducted and he presented at CTOS on behalf of the team, where basically we looked at, this is cellular data, looking at primary mutations versus resistance mutations. So let's take a minute to look at this slide, where basically much of this is what we see clinically as well, but this is again a cellular-based assays, where we see the green is there's inhibition in these particular mutations by these particular drugs. And the red, not so much, and that's blockage. And then the yellow is kind of in between. So clearly we know of the most common mutations, we see activity from imatinib in exon 9 and 11. But these secondary resistance mutations, we do not see. We start to obviously develop resistance to imatinib. Sunitinib seems to target some of these, exon 13 and 14 particularly, and Regorafenib comes in with exon 17. This was an experimental agent that was part of the study we conducted here. And then Avapritinib really has a broad range of activity, but just because we see a broad range of activity in a cellular basis, we know that it doesn't always translate as to the best drug for a given patient. And here we don't have our PDGFR mutants noted. And then Ripretinib, as you can see, also has a broad range of coverage of the resistance mutations. And again, this is an experimental combination that we use. So kind of in summary, when we just think about now switching gears, instead of thinking about specific drugs, thinking about specific mutations, what we know and what we generally consider when we can get the data is the initial management strategies. For KIT exon 11 mutations, we know that imatinib 400 milligrams a day is an excellent strategy. And this is our most common mutation. For exon 9 mutants, we can use imatinib 400, but we know we may have better activity if we escalate to 800 milligrams, if possible. Some patients can tolerate it quite well. This is our PDGFR alpha exon 18 mutations with the D842V variant. We know that these are typically imatinib-resistant, so we would lean towards Avapritinib as an initial treatment. In the non-D842V variants, Avapritinib certainly does have activity, but so does imatinib, and usually is still our first choice. But again, we're learning so much about our strategies every day. And some of the other non-exon 18 mutations are still very reasonable to start with imatinib. And again, we use this information particularly in tumors that are thought to be imatinib resistance. And I kind of starred some of these SDH deficiencies. There's different ways we've learned how to be SDH deficiencies typically are resistant to imatinib. And so we often try kind of some of our tyrosine kinases that have some VEGFR antagonism, such as sunitinib or Regorafenib. And then kind of, moving on to our, our more rare GIST mutations, which in general tend to be imatinib resistance. And again, these are fairly rare, as our pathologist pointed out. There's different changes we've seen with TRK fusions and other fusions. Patients have reportedly had incredible benefit from TRK inhibitors when these are identified. And if one associated to GIST tend to be imatinib resistance, and there may be a role for MEK inhibitors. BRAF mutations are also fairly rare, but there have been some reported benefit from BRAF plus MEK inhibitors, as well as Regorafenib, that can hit along that pathway. FGFR alterations, amplifications, or fusions can be targeted with FGFR inhibitors. There's very minimal data in terms of the best approach with some of these rarer variants, but we know anecdotally there has been benefit, and we will probably hear some more from our next speaker about some of these rare variants. So I did want to point out, for clinical trials really are the optimal strategy for some of these rare mutations, and often they're in the form of kind of bucket studies based on their mutational testing, not necessarily GI stromal tumor studies. So it's important to kind of look broadly. And then lastly, secondary GIST mutations, we talked about that we can do liquid biopsies and get additional resistance mutation information in some situations, and that can be useful in guiding treatment. A lot of times that data isn't able to be received, and we do almost our trial and error approach. But when we can, we know that exon 13 and 14 changes, sunitinib does have some activity, and there is some overlap here with Ripretinib, and then there are secondary resistance mutations in exon 17 and 18, which is in a different location in the KIT tyrosine kinase, can be amenable to Regorafenib or Ripretinib blockade. And there's definitely clinical trials that are ongoing to address this resistance with combinations and new agents. And then one last topic is really, what about mutations when we consider adjuvant therapy? The studies of adjuvant therapy did include multiple mutations, and really only included imatinib is studied as an adjuvant therapy. What we know in general now is that even though the studies included all different types, imatinib as an adjuvant therapy or a preventative strategy is probably not appropriate for those with imatinib resistance mutation. So that's where that information can be useful in the preventative setting. So with that, to summarize kind of our mutational analysis, how it guides treatment, for most GIST patients, imatinib is still our first choice, and the exception is for imatinib-resistant GIST. And these are some examples of those. We could also consider initial dose escalation of imatinib with exon 9 mutants. And then our kind of second, third line treatments have activity across many mutations, but some do favor one drug over the other. And then lastly, imatinib is the only treatment approved for kind of preventative treatment. But we could consider other agents if imatinib intolerant based on the mutation type. So I know that was a lot of information. So hope that was helpful. And with that, I'd like to really, again, thank the team for inviting me and all the patients and advocacy groups, including the whole sarcoma team at University of Michigan, as well as many of my colleagues internationally.
Excellent. Thank you so much for this presentation. It was excellent. I think it really makes a case about how important it is to get mutational testing done to help inform the oncologist about a treatment plan. And I think you laid that out really well in terms of the protocol about which way to go. So thank you very much for that presentation. Marcus, should we move on to the next presentation?
Yeah, I would, in the interest of time, we should move forward. So it's my pleasure to introduce our next speaker. Many of you know them, I think, for many, many years, because he was with us from the very early beginning with New Horizons, but also with Sarcoma Patients Unit. And I'm talking about Peter Reichert. Peter Reichert is one of the leading sarcoma GIST experts in Germany, running one of the sarcoma centers here in Germany, but also very well known as an international GIST and sarcoma expert. And he's also with us in the patient community from the very early beginning. And as I mentioned before, he's my co-chair of the new Sarcoma Foundation here in Germany. It's my great pleasure to introduce Peter.
Okay, Marcus, thank you very much. Welcome everybody around the globe. It would be nice to see a real globe with all little sticks put on at places where people come from. So Sarah and Marcus, maybe you can generate that. That would be very nice to show the globe could circulate and we could imagine a lot of fancy things. But let's come back to the topic, mutation analysis in GIST. And we already heard excellent presentations. So I was asked to share a couple of real patient cases from our daily practice with you, showing how exactly mutational testing may indeed impact treatment decisions in either way.
Peter,
So, yes.
You have now a difficult mode to look at. Wenn du auf den Anzeigeeinstellungen einfach oben mal, siehst du das oben bei dir am Bildschirm? Da ist so ein Präsentationsmodus. Wir haben jetzt immer die Vorschau schon.
Okay.
Oben steht Anzeigeeinstellungen in dieser oberen Menüleiste in der Mitte. Wenn du darauf klickst, kannst du das ändern.
It's better now. Maybe this one.
We still see. Ah, yeah. That's great. Fantastic. Thank you.
Oh, so you only see the correct slide, the title slide now?
Yeah.
Okay, okay. All right. So now you should see patient case number 1. Is that correct? Okay, great. Thanks, Eva. So the first case I want to discuss, that is a male patient, 64 years of age, had gastric discomfort for a couple of months. Gastroscopy revealed a large tumor. Obviously, a GIST was suspected. Biopsy did finally confirm GIST. An abdominal CT scan did not show any further lesions, so localized disease, and the patient underwent a surgical resection. Histology came up with a very large GIST, 12 centimeters, medium number of mitosis, 6, but that's still more than 5. So using one of the most common recurrence classification systems, this would account for a high risk of recurrence. And the patient was then started on imatinib therapy and was told that standard of care would be 3 years. So at that time, what you are missing is the mutation analysis. And actually at that time point, the patient came to our center to see me and ask whether this is the correct recommendation. So obviously, as we always point out, without knowledge of mutation analysis in such a case, you cannot give a treatment recommendation. So I told the patient their essential information is missing. We have to ask for mutation analysis. And once the information is there, I can give him a correct recommendation. So it was done. and not unexpected for a large gastric GIST. The mutation analysis did show the PDGF receptor alpha exon 18 D842V mutation. Now, is this a very rare situation? The answer is no. Eva Wardelman and others have shown that for a gastric GIST, the likelihood of this mutation is near 20%. So every 5th patient with a gastric GIST carries this exact mutation. So that is not a very rare thing, but it's not uncommon for the gastric location. Very rarely outside the stomach, but in stomach around 20%. So in this specific case, without mutation analysis, the patient would have undergone adjuvant imatinib therapy for 3 years with all the possible, mostly not very problematic, but in exceptions can be. So with all possible side effects and all the costs associated with 3 years of adjuvant imatinib therapy. Now, based on the mutation analysis, we immediately recommended to stop imatinib, and the patient went on follow-up without further therapy. And so far, it's a couple of years since then, the patient did not show a recurrence. So in this situation, we saved the patient 3 years of imatinib, and we saved the community a couple of €100,000, which at that time, the therapy would have costed. Next case, another male patient, 68 years of age, underwent surgical resection for his GIST. Histology, again, a large GIST, 8.2 centimeters, quite high number of mitosis, 36. Again, high risk of recurrence. And also this patient was put on adjuvant therapy for 3 years with the information, mutation analysis already underway, but the recommendation was that we start, but we wait for the result, or we will make a change in treatment once we have the result. Then the result came, and the mutation analysis did show a PDGF receptor alpha exon 18 mutation, somewhat different from the most common. So the treating physician in private practice, not a real GIST expert, only recognized, well, that's the PDGF receptor alpha exon 18 mutation. Obviously thought about that is the typical one and recommended the patient to stop imatinib therapy, assuming that this would be the classical typical imatinib-resistant mutation. Again, the patient came to see us for a second opinion. And the second opinion, we told the patient that this specific mutation with this deletion in exon 18 is expected to be imatinib sensitive. You remember one of the last slides from the previous speaker, that non-D842V exon 18 mutations are expected to be imatinib sensitive. So in this case, we told the patient and recommended to restart imatinib. This patient, based on the very high mitotic count, has a quite high risk of recurrence. The mutation is expected to be imatinib sensitive based on very small numbers. That is an extremely rare mutation. So expected to be imatinib sensitive. So in this case, the recommendation was to restart imatinib 400 milligrams for 3 years. And for this patient, that happened a couple of months ago. So the patient is still in the early part of his adjuvant therapy in the first year. But for this patient, it may make a huge difference to restart adjuvant imatinib compared to no adjuvant therapy. So again, a major change in decision. Third patient is a female, 56 years of age, with a duodenal GIST, 7.5 centimeter, 3 mitosis. The mutation analysis done initially did not show a mutation in KIT, no mutation in PDGF receptor alpha, no mutation in BRAF, no SDH deficiency. So that is the small group of patients with what we still use to call wild type, normally wild type in parentheses. So consequently and correctly, the patient was not offered adjuvant therapy based on risk and absence of any activating mutation. 3 years later, the patient unfortunately developed liver metastases. And the first decision at that time with liver metastases in a patient with a GIST with no activating mutation is that we first recommend a follow-up to get an idea how aggressively the lesions are growing, how aggressive the tumor is. It's what was already mentioned, I think, from Eva Wadelmann earlier on today, that some of these cases do show quite indolent disease, so you never know whether it will grow more rapid or not. So our first recommendation is not immediately start treatment, but get a follow-up. After the first 3 months follow-up, there was absolutely no change. So we told the patient, maybe patient is lucky and there is an indolent cause. So we recommended another follow-up 3 months later for an overall of 6 months. But unfortunately, at that time, there was a progression in the liver metastases. So we discussed the treatment options. And as you have seen in the presentation of Rashmi in the previous talk, in these situations, imatinib is not helpful. There is absolutely no target available on which imatinib would act. So it absolutely does not make any sense to use imatinib. And our standard choice for these cases is to use sunitinib. The important thing is to use a flexible dosing. Flexible dosing means that you make an individualized treatment plan with respect to the daily dose and with respect to the schedule of treatment, yes, and treatment interruption. So the on-off and the daily dose has to be individualized for best possible outcome. This did work quite nicely in this case. So 2 years later, 2 years of flexible imatinib dosing, the patient had a focal progression in 1 liver metastases. So we offered a localized treatment. Surgery was not the treatment of choice based on the localization of the growing lesion. So we did a selective intra-arterial radiation therapy, abbreviation SIRT, which worked quite nicely. At that time, we repeated the mutation analysis with a specific focus on looking for an NTRK fusion. This was already shown. That is an extremely rare event. It's below 1%, probably much lower, but there are very few GIST cases with no other mutation where you can eventually find an NTRK fusion. In patients where you can detect an NTRK fusion, the clinical benefit rate is nearly 100%, so extreme rare, but the eventual patient with this molecular finding has great and prolonged benefit from a specific treatment, which in the case of this patient, unfortunately was not present, and therefore the treatment targeting NTRK fusions was not possible. So we decided to continue sunitinib with a flexible dosing. And it's now working for nearly 3 years. The patient was recently seen by me. She's now on 34 plus months of sunitinib, and still has stable disease. The only growing lesion 1 year ago was treated by SRIT, as mentioned, and the rest is still stable with sunitinib. And we hope that the stability will continue. The patient is doing very well with her specific dosing and leading a nearly normal life. The fourth case is a very young female, 25 years of age, and all of you who have carefully listened to Eva Wadelmann's presentation do suspect what the specific mutational situation in this patient will be. And indeed, GIST of duodenum, lymph node metastases, liver metastases, that started back in 2016. The patient was started on imatinib before the availability of a mutation analysis, which took somewhat longer outside our institution, I might add. And when the mutation analysis finally arrived, the result did show, as was expected for a young female patient with lymph node metastases, and revealed an SDH deficiency. Now, we have already learned that in this situation, imatinib is not a useful therapy. So imatinib was stopped. The question of what is best in this situation is still somewhat unanswered. We know that imatinib does not work. Possible treatment options are several. And this patient, that's why I mentioned that this is already 5 years ago, underwent numerable treatments with different results. The first treatment, that's our usual first choice in SDH deficiency, still is, may change in the future, but still is sunitinib. The benefit was 8 months. Next line of treatment was Regorafenib, which worked for 6 months. Then we offered the patient debulking surgery. From this resected specimen, we did another extensive molecular profiling, which interestingly showed an FGF4, that is for fibroblast growth factor 4 overexpression. That is something seen in different types of cancer, not at that time point, but now there are some specific treatments available for FGF overexpressive cases. This patient was then also offered the local treatment already mentioned, SIRT, selective intraarterial radiation treatment. Then the patient with further progressive disease was put on lenvatinib. Lenvatinib is another multi-targeted tyrosine kinase inhibitor. And the reason we did use this was that lenvatinib is very active against FGFR. That is the receptor, fibroblast growth factor receptor. That is the receptor that is activated with FGF4 overexpression. So based on this knowledge, FGF4 overexpression, we offered the patient lenvatinib. That is an agent not usually used in GIST. So the target here was FGF. That worked very nice with a response, but unfortunately the patient developed intolerance and could not tolerate further treatment. So we had to stop therapy, even in facing a nice response of the liver lesions, but the patient could not tolerate further treatment. So we switched to ponatinib, also active against FGFR, and finally cabozantinib, sorry, that must be an O, cabozantinib, also active against FGFR. Unfortunately, over time, the patient developed further progression. So we then started some sort of chemotherapy. And you will remember again from Eva Wadelmann's presentation, that there is a hypermethylation resulting from SDH deficiency. And decitabine is a drug that works as a demethylating agent. So it removes the hypermethylation. That is some of the problems with the HDH deficiency. The patient received 4 cycles with some disease stabilization, unfortunately not prolonged, so we had to stop this. We then offered another TKI, Pazopanib, which unfortunately did not work. Then we completely changed the strategy to another therapy that was recently reported to be of possible benefit for the SDH deficiency subgroup of GIST. That is a classical chemotherapy, quite commonly used in some subtypes of soft tissue sarcoma. That treatment was started in January. It's still ongoing, and fortunately, we do see an ongoing response with slight shrinkage of liver metastases and improvement in clinical feeling of the patient. Now, what is the background here? That is data, that is data recently reported from colleagues at the Connective Tissue Oncology Society in November 2020, so not very long ago, showing that temozolomide, that is actually the oral version of dacarbazine. So dacarbazine is an infusion and temozolomide is a tablet, but it's basically the same drug. So these colleagues in the US did use temozolomide, and as you can see, they treated 5 patients, and most patients derived benefit. They reported 2 partial responses with a very nice shrinkage in these 2 green bars, and these 3 patients at least did not progress. So in our patient, we have a slight shrinkage, not yet qualifying for a partial response, but that is fully in line with the experience in this presentation from the CTOS conference. Well, you may think that this is completely new information from 2020, and the final slide I will show you is a very nice, interesting piece. I would like to show you more than 20 years ago, exactly 21 years ago by now, Peter Reichert had a presentation at the American Society of Clinical Oncology conference. I want to show you here. At that time, we presented a study with continuous infusion dacarbazine, DTIC, in heavily pretreated patients with different soft tissue sarcomas. And in the conclusion, we wrote, this was not a very active therapy. However, 7 patients with progressive leiomyosarcoma or GIST showed stabilization of disease for 2 to 11 months, supporting at least some activity for this subgroup of GIST. So this shows that the activity of dacarbazine in GIST is not completely new, but was already reported 21 years ago. So that's a nice, yes, Sarah, thank you. Actually, that came back to my mind when I learned about the CTOS present, or when I listened to the CTOS presentation, I thought, oh, that's interesting. We did something like that a long time ago. And then I went to my archives and looked for this presentation. I found it in the folder containing abstracts back in the year 2000, where we presented this piece of clinical research. So this is somewhat supporting what colleagues now worked out recently our patient again is continuing on this therapy, and we hope that it will help her for some more time. So that concludes the presentation, and I hope I could show you a couple of examples where mutation analysis made a major impact, or at least helped us defining the best possible therapy for our patients. Thank you very much.